comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home of the Métis Nation of Alberta, Districts 5 and 6. We would also like to acknowledge the University of Calgary, the University of Alberta, its buildings, labs, and research stations, which are primarily located on the territory of the Cree, Blackfoot, Stoney, Iroquois, Ojibwe, that are now part of the Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta represents the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. With that, we also like to acknowledge that we are encouraging a brave space where active listening, respect, inclusiveness, but also open and honest dialogue. This seminar will be recorded, but just for the talk part, we will have a question period where we will turn the recording off. So that's just to encourage a safe space for questions.
Awesome. Thank you, Margaret. So we'll start off by introducing our first speaker today. We have Dr. Christopher Power, and he is a physician scientist trained at the University of Toronto, Ottawa, and Western Ontario, as well as McMaster and Johns Hopkins universities, and the National Institute of Health and Medicine, Neurology, and Virology. He is a professor at the University of Alberta and holds a Tupin Chair in Neurocognitive Disorders and is the founding co-director of the University of Alberta Multiple Sclerosis Centre. He has held numerous prestigious awards and positions, including a Tier 1 Canada Research Chair in Neurological Infection and Immunity, and his research group is recognized internationally for discoveries in viral infections of the nervous system, which is associated with innate immune responses, particularly focusing on HIV, COVID-19, and multiple sclerosis. Dr. Power is an active clinician working in HIV clinics in Edmonton and Calgary, as well as the MS clinic in Edmonton. He holds several patents related to his research on innate immunity, and he has trained and mentored several tens of students, fellows, and residents, and junior faculty members who have gone on to very diverse and successful careers. So with that, I will pass it off to Dr. Power.
Thanks. Thank you very much for that kind introduction. And thanks to the Alberta Pain Research Network for inviting us to speak. I'm privileged today to be able to present with Isabelle Tottenham. Perhaps you'd like to just introduce Isabelle, but before I forget to say any of this, we don't have any personal disclosures, financial otherwise. The research group is funded by CHR, MS Canada, and other NGOs, but we won't make any comments that are relevant from a commercial perspective. Thank you.
Thank you. And yeah, I'd be happy to introduce Isabelle as well. Here, I can share my screen one more time. There we go. So Isabelle grew up in Parksville on Vancouver Island, British Columbia. She moved to Alberta to complete her Bachelor of Science in Neuroscience at the University of Alberta, where she researched neuropathic pain in multiple sclerosis for her honors thesis under the supervision of Dr. Brad Kerr. She then completed her Master's of Science in Neuroscience exploring a novel therapy for remyelination in MS at the University of Calgary, and she is currently in her second year of medical school at the University of Alberta doing research in the field of peripheral nerve injury. So thank you so much for also joining us, Isabelle.
Great. Thank you. One fun fact about each of us. I grew up on a farm, but I clearly was not cut out for farming. And I've enjoyed being a clinician and a scientist for many, many years, and I continue to enjoy doing it and want to continue doing it indefinitely, unfortunately, for those around me, but I still am very excited about science and clinical care. Isabelle, do you have anything you want to disclose?
Dr. Power asked me to come up with a fun fact. He requested that I talk about the fact that I have a dog who I love very much. His name's Benson. He's a black lab, and he's a very good dog that I do a lot of activities with. And that's my fun fact.
Yeah. Okay. Yeah, Benson's an active part of your life for sure, right?
Very active, yeah. Yes. I'll share my screen and then we can get started. Perfect. So as mentioned, today we're going to be talking about neuropathic pain caused by viral infections, specifically highlighting COVID-19, HIV, and varicella zoster virus. So what our talk will look like today is we'll go through some core concepts of neuropathic pain. We'll talk about the mechanistic framework for viral neuropathic pain, and then some specific mechanisms behind the 3 infections that I previously mentioned. Following each infection, Dr. Power will come in and give kind of a clinical vignette and talk about a case related to each of these diseases. So to get started, the International Association for Research of Pain defines pain as a direct consequence of a lesion of the somatic system. There is and when we look at the national burden, specifically in Canada, you'll find that neuropathic pain affects about 1 in 10 adult Canadians. What we will specifically be talking about today is post-infectious neuropathic pain, which is quite common and an under-recognized syndrome of pain. So to talk about neuropathic pain a little bit more, it can be caused by a variety of etiologies. So what we'll be talking about today is infectious, kind of post-infectious syndromes, but there are other causes of neuropathic pain as well. So that includes things like diabetic neuropathy, there's direct trauma or injury to a nerve, you can have nerve compression, you can have metabolic dysfunction, for example, imbalances in lipids, you can have autoimmune diseases such as MS or lupus, Sjogren's, or vasculitis, where you have syndromes of neuropathic pain. It can also be caused by toxic agents such as medications or alcohol use disorder, which is AUD. So some of the key features we wanted to highlight related to neuropathic pain, one being allodynia, which is pain from a stimuli that should not normally provoke pain. There's hyperalgesia, which is severe pain from a usually mild to moderately painful stimulus. There's also dysesthesia, so this is commonly described as things like pins and needles or electric shocks, just unpleasant and abnormal sensations that patients experience. There's also numbness and tingling, and then there are also these complications associated with neuropathic pain. So these can include challenges with ambulation, challenges in sleep, cognitive deficits, and pretty significant mood disturbances as well. So the mechanisms of neuropathic pain that we want to highlight here, we'll talk about peripheral and central sensitization, and then I'll talk a little bit about the kind of like immune modulation component as well. So just to introduce peripheral and central sensitization for anyone who's not aware of these, so peripheral sensitization is this increased sensitivity to pain at the site of tissue damage. This is occurring in the peripheral nervous system compared to central sensitization, which typically arises in the dorsal horn of the spinal cord in the central nervous system, and it's associated with this like heightened state of reactivity within the CNS and amplifies pain signals. So we'll just go a little bit more into the mechanism of peripheral sensitization, and I'll take you through this slide from left to right. So peripheral sensitization typically starts with a form of tissue damage and injury that leads to this what's called an inflammatory soup of cytokines and mediators that are released. So things like prostaglandin, bradykinin, histamine, ATP, protons, all of these things contribute to the eventual development of peripheral sensitization. These bind to the nociceptors, and they will activate these intracellular secondary messenger pathways, so PKA and PKC. This leads to the phosphorylation of transmembrane proteins, specifically the ones that we see in peripheral sensitization are voltage-gated sodium channels, 1.7 and 1.8, TRPV1 and TRPA1. And all of this kind of leads to this lower excitation threshold. So the lower threshold means that a previously non-painful stimulus might be painful, and there's more action potentials that are firing. And these activated neurons also release mediators like substance P and CGRP that can exacerbate the inflammatory cascade. And they do this by vasodilation, recruitment of immune cells, and amplification of the immune response. So to kind of summarize all that up, the big points we want you to take home here is that there's this increased sensitization of peripheral nociceptors, specifically through the voltage-gated sodium channels, the inflammatory milieu, which kind of leads to an increase in glutamate, our excitatory neurotransmitter, and a reduction in the inhibition with GABA. There's immune cell infiltration, and the consequences of this is that there's a lower threshold for activation. You have nociceptors that are firing spontaneously and easier, and there's an increased response to previously potentially non-painful stimuli. So now we'll summarize central sensitization. So this is where we've moved into now the dorsal horn of the spinal cord, the area of the spinal cord that is typically used for processing and modulating pain and sensory information. So in central sensitization, you have this triggered kind of repeated and intense noxious stimuli from typically from peripheral sensitization. So this is from the sustained release of glutamate and substance P. And then you have this persistent afferent input. It leads to AMPA receptor activation and depolarization of the membrane, which then removes the magnesium block from the NMDA receptors. With the removal of this block in the NMDA receptors, calcium infiltrates the cell, and you have phosphorylation of intracellular kinases such as PKC and PKA again. And there's phosphorylation of this leading to the amplified pain signal, as we discussed. And there's kind of a secondary component to central sensitization as well. And this is the first component was more activity dependent. The second one is transcription dependent. So the CNS will undergo these kind of structural and chemical neuroplastic changes where there's an increase in the gene transcription centers for things like CFOS and COX2, and it causes these neuroplastic changes that create pathways that allow the pain signals to travel more easy and the pain inhibition to be reduced. So with this structural remodeling, it kind of leads to these permanent connections that favor pain transmission. And there's this hyperexcitable site with glial cell activation. So all that to say, kind of the big points we want you to take home from central sensitization is that there's this increased excitability in the dorsal horn of the spinal cord, so the central nervous system. You have NMDA activation through substance P and CGRP, neuroimmune activation, and then those structural and functional changes we talked about. And the consequences of this is that you have the pain amplification, there's allodynia, and there's kind of important point here is that there's pain even after the peripheral tissue is healed. So you have this heightened pain even though there's kind of no source of it anymore in the periphery. And the last kind of framework we'll talk about for neuropathic pain is the neuroimmune interface. So what we want to highlight here is that it's bidirectional communication between the immune system and the nervous system. There are quite a few cellular and immune players within this interface, so microglia, astrocytes, macrophages, T cells, and more. And some of the key mediators behind the neuropathic pain pathogenesis are cytokines, chemokines, and neurotrophic factors. So cytokines, IL-1 beta, it acts kind of directly on the sensory neurons and increases excitability. You have IL-6, which acts on the JAK-STAT pathway, and it within microglia and astrocytes, and it will within the spinal cord and kind of heighten that pain amplification. TNF-alpha is pretty commonly known. It's released from injured nerve cells and glial cells, and it increases the neural sensitivity to pain. You have chemokines, so CCL2 is a pro-inflammatory chemoattractant for monocytes, T cells, and dendritic cells. And then you have neurotrophic factors as well, such as BDNF, which is brain-derived neurotrophic factor. It's released by microglia in injury and acts on TrkB receptor and reduces the potassium chloride cotransporter 2. And essentially that causes this depolarizing shift that weakens the inhibitory function of GABA. So also say that you have all these components of peripheral, central sensitization, and neuroimmune that contribute to the development of neuropathic pain. So now moving into the viral component, which is what we were talking about to you today. Oh, yes, this is just a summary, that there's persistent neuroinflammation and the maintenance of central sensitization. But now we'll go into the actual mechanisms of viral neuropathic pain. So these are some examples of how viruses can induce neuropathic pain. So you have direct neurotropism, which is where the virus can directly invade and replicate within the nerve cell and cause damage. There's immune-mediated injury, which we touched on briefly with that neuroimmune modulation component. There's latency and reactivation. So this is when a virus establishes a lifelong latency within cells in your body And then with declines in immunity, the virus can reactivate and cause nerve damage or chronic inflammation or pain. And then there's also direct damage to small nerve fibers, so the A delta and the C fibers that carry pain signals. Okay, now we're going to get into the three common viruses that we'll talk to you about today. The first one being varicella zoster virus. So this virus belongs to the family of orthoherpesviridae. It is, many people might know it as chickenpox if you had it as a child, and the primary infection is by varicella. So it causes chickenpox. It's this pruritic vesicular rash that usually starts on the face and trunk and spreads to the limbs. And it can be associated with fever, malaise, and headache. And when you are infected with this virus, there's lifelong latency in the dorsal root and cranial nerve ganglia. And this can be reactivated in adulthood, and it comes reactivated as in the syndrome of shingles. So this is with herpes zoster. And you get a dermatomal rash, which we'll show pictures of in a few slides, and an acute neuritis. It's typically triggered by things like stress or inflammation, immunosuppression, or aging. And the key pain syndrome that we want to highlight here related to this post-infectious neuropathic pain is that you can get post-herpetic neuralgia. So this is defined as a over 90-day persistent neuropathic pain, and it affects about 10 to 20 cases of patients with shingles that are over 50, and you essentially get persistent pain even after the rash is resolved. So we're just going to show some images here. This is chickenpox, so that initial primary infection of varicella, both on the left and right, and usually spreads to the limbs, and again, typically resolves over time. And then we'll talk about a few more manifestations of now, this is adult varicella zoster virus. On the first image on your left, you have herpes zoster shingles. So you can see that unilateral dermatomal distribution kind of in the T3 area here of the rash. The second one in the middle is herpes ophthalmicus. So this is actually when the virus invades the ophthalmic nerve of the trigeminal ganglion, and it's a vision-threatening condition, so quite emergent. You get an itchy rash over the scalp and eye, and again, vision-threatening, so very important to be treated. And then last on the right is zoster synherpetae, which is a more rare manifestation, but it causes severe pain or neuralgia. You can get a palsy with it as well, but it's without that characteristic rash. You can see that it's not very present there. And then the next manifestation is this. So this is multidermatomal herpes zoster, and it's important to highlight because it can be a sign of immunosuppression in patients. And you can see that it's across multiple dermatomes there. So this is a summary of how varicella zoster can cause neuropathic pain. So in the top left, A, through direct neural injury, we talked about how you can have inflammation of the and axonal degeneration of the neurons themselves. In B, there's inflammation, so there's immune-mediated release of cytokines and chemokines that cause damage. And then the bottom two figures are just showing the peripheral and central sensitization that we previously introduced. And now I will hand it off to Dr. Power for going over a case.
Yeah, thanks, Isabelle.
Add anything?
Yeah, so we have an example of a case. It's not there are no identifiers, so no concern about confidentiality, but this is a 65-year-old white male, really with only past history of hyperlipidemia. And the patient noticed insidious onset of an itchy discomfort, kind of like what Isabelle described, sort of so-called dysesthesias over the left scapula. And the symptoms escalated to a burning sensation with an eruption of vesicles that similar to what Isabelle showed you a couple of slides earlier. And that occurred about day 3 and post onset of the symptoms, and it was accompanied by a sense of fatigue as well. The patient was fortunate to be able to be seen by neurology fairly expediently at day 4 post onset, and immediately it was recognized that valcyclovir was required because the patient had shingles, and they started on 1,000 milligrams 3 times a day for 7 days, which is really sort of that's based on good randomized controlled trials supporting it. And then by day 5, There was some persistent allodynia, but there was crusting of the vesicles that became evident. Next slide. On exam, typical of shingles is really no motor abnormalities. Cranial nerves were fine, and the deep tendon reflexes were also preserved as well. However, there was marked hyperalgesia over the T3 dermatome, essentially over the left scapula. And so the diagnosis is pretty clear. There wasn't any need for further tests like spinal fluid analyses or anything. It was clear that it was herpes zoster or shingles, and it was monodermatomal shingles. So there are no red flags for immunosuppression, and it's clearly caused by reactivation of VZV. And so the patient was treated with valacyclovir, and by 10 days, symptoms have pretty much resolved. And most importantly, there was no sequelae of post-herpetic neuralgia. And I think that's a really important point to drive home. That not only does valacyclovir hasten the recovery, but it also reduces the risk of post-herpetic neuralgia. So there is some onus on people. Sometimes people will say it's not severe enough that it warrants treatment, because like any medication, valacyclovir has side effects, impacts kidney function, but nonetheless, it actually reduces the risk of post-herpetic neuralgia, which can be really very disabling for patients down the road. And that's most apparent in elderly patients who get zoster. But you can imagine if you've got herpes ophthalmicus, if you get post-herpetic neuralgia there, it's wickedly uncomfortable, and it really I guess the take-home message is, if you suspect zoster, herpes zoster, treat it expediently, because time is also an issue. The quicker you get the treatment on board, the better patients do. Okay. I think that's good for that.
Awesome.
We'll move on to the next one.
Yeah. So next, we're going to talk about HIV infection. So HIV infection is a chronic viral infection. It affects the immune and the nerve system, targeting CD4 positive T lymphocytes and macrophages. There's typically 3 stages of HIV. So the acute stage, where it occurs 2 to 4 weeks post-exposure. You have symptoms such as fever, headache, rash, sore throat, or swollen lymph nodes. And then it moves into more of a chronic phase. So there's typically more asymptomatic or clinical latency while the virus reproduces at low levels or replicates at low levels. And then it can move into an advanced stage of the disease, which is defined as a very low CD4 count, typically below with 200 cells. And this kind of opens you up to opportunist infections, weight loss, fatigue, and fever. The key pain syndrome that we want to highlight with this infection is distal sensory polyneuropathy, and then we'll also talk a little bit about NRTIs as well. But just to take you through the clinical course of HIV infection. So following the blue line, so that's your CD4 positive lymphocyte count, your primary infection occurring, and your CD4 cells going down and continuing to go down as the rate of HIV RNA copies goes up. So in that first kind of few weeks, you can see that there's the acute HIV syndrome. There's a wide dissemination of the virus. The clinical latency, where the HIV RNA is replicating in low levels, and then later stages of the diseases, which is considered where you're getting symptoms of AIDS and opportunistic infections. So previously, they would start treating patients later on, so close to kind of the 9 to 10 year timeline here on the slide. But now with antiretroviral therapy, we now treat much earlier. So treat as soon as acute HIV syndrome is recognized, and it's typically a very well-controlled virus today. So HIV distal sensory polyneuropathy, it affects about 20% of HIV infected patients. It's a small diameter neuropathy, again, so it's A delta and C fibers. DSP, it worsens with HIV disease progression, so it's a good clinical marker of that. And some of the neuropathic features that are experienced by patients with HIV are allodynia, hyperalgesia, dysesthesia, and then to note, there's also autonomic symptoms, so bladder and bowel dysfunction, and they can also have some gait impairment as well. In the next slide, we're showing the epidermal nerve fiber density of a patient without HIV, so that's on the left, versus a patient with HIV on the right. So you can see on the left, the arrows are pointing to the epidermal nerve fibers, and there's a reduced density in those patients with HIV. And again, this is a good correlate with disease severity. So moving on, just to quickly touch on antiretroviral toxic neuropathy, it's not seen as much anymore because it was associated more with dysfunction from the older nucleoside reverse transcriptase inhibitors, NRTIs, that were used to treat the disease. So this is a sensory peripheral neuropathy. It's caused by mitochondrial dysfunction. NRTIs target reverse transcriptase inhibitors, but they also competitively inhibit DNA polymerase gamma, and that is the enzyme for mitochondrial DNA. And so with the inhibition of this, there's depletion and dysfunction in peripheral nerves, and it leads to this clinical syndrome, which we see as a symmetric burning pain and numbness in the stocking glove distribution, which is essentially saying that you get this distal neuropathy in the hands and feet, and it kind of moves up over time. And these were, again, associated with those older NRTIs, so what they call the D drugs, but it is a neuropathy associated with HIV. So this slide just, again, summarizes the mechanisms of neuropathy with HIV. On the right-hand side, or on the left-hand side, sorry, you'll see there's indirect neurotoxicity. There's also direct neurotoxicity, where the HIV infects the neurons. And with indirect, if HIV can't kind of enter the neuron and replicate effectively, it will produce neurotoxic substances such as GP120 and VPR to attack the nerve cells. B, again, showing that there's immune activation associated with HIV neuropathy, the mitochondrial dysfunction we talked about with the NRTIs, and then there's this small fiber involvements, the A delta C fibers, that are directly damaged and causing the neuropathy. To the case.
All right, thanks, Isabelle. So this is a case, actually, this is a patient whom I care for actually in the Calgary clinic. And she's a 50-year-old white female. She's had HIV for about 20 years. She's been receiving effective antiretroviral therapy for many years. Nonetheless, she presented several years ago. She reported that she had discomfort in her feet for the past 6 months. So this is pretty typical. There's sort of this insidious onset. And it started out with pins and needles, and then it evolved into sort of dysesthesias and a burning sensation. And it often is asymmetric, this type of neuropathy. So in this case, it was worse on the left and the right. The other thing is it was principally in her feet. So Isabelle just talked about antiretroviral related neuropathy, but that is very symmetric and involves the hands. But the typical pure HIV neuropathy caused by the virus itself is typically involves the feet, much less so the hands, and it can be asymmetric. Her symptoms are pretty classic. The symptoms awaken her at night. The bed sheets were uncomfortable on her feet. She didn't want to sleep with sheets on her feet, and she often reports that she reported that her shoes feel too tight. In fact, I've even had patients who've cut the top of their shoes out, such that there's no contact of on the upper surface of the foot because it's so uncomfortable. And she also reported feeling unsteady while walking, which is indicative of sensory loss, but she hadn't had any falls. Importantly, she's been on an antiretroviral that is not neurotoxic. She's on 3-TC and dolutegravir, and her viral load is undetectable in blood, which is where we'd like to see it, and her CD4 count is over 500. Normal CD4 counts anywhere from about 800 to 1,000 cells per microliter, and hers is above. It's not anywhere near the AIDS level that Isabelle mentioned earlier, but it's not quite back to baseline, but she has no viral load in her, no viral detection in her blood. Next slide. So on exam, typical of this kind of condition, the cranial nerves were unremarkable, her coordination was good, and actually her motor exam was also fine. This is principally a sensory neuropathy. However, she did have hyperalgesia over the ankles, and then in her feet, there was reduced light touch temperature and vibration in her toes, but there was preserved proprioception. Her deep tendon reflexes were intact in the arms, as you expect, a little bit reduced at the knees, and absent in the ankles with reinforcement, indicative of peripheral nerve injury. And also, for those of you who are interested, she didn't have any evidence of spinal cord or brain disease, so-called upper motor neuron involvement, in that her plantar reflexes or her toes were down going, so not Babinski positive. She was able to walk in tandem, which is a good measure of balance, but her Romberg test, which is really indicative of sensory changes, was positive. And importantly, when we did her blood pressure, she had a 30-point drop in her systolic blood pressure without any compensatory change in heart rate, suggesting that there was an autonomic component to her neuropathy, which is very common amongst this group of patients. Next slide. So at that point, I felt pretty confident this was HIV-associated distal sensory polyneuropathy, typically a small diameter fiber neuropathy involving C fibers and A delta fibers. However, it's always imperative to ensure you don't exclude other possibilities. So could this be a post-neurotoxic antiretroviral exposure? Unlikely. She hadn't really been exposed to them. We rarely use those drugs, if ever, anymore. Could it be diabetic neuropathy? Yep, definitely, except she had no motor features. There was no atrophy of the muscles. There was no obvious weakness. Could it be syphilis? Yeah, definitely. We're having a resurgence of syphilis today in Alberta. So that was a consideration. And then other vitamin deficiencies. B12, typically not painful, but nonetheless worth keeping in mind. And B6, definitely, but that would really require marked nutritional deficits. So she had a pretty broad workup. We wanted to exclude diabetes. We wanted to exclude syphilis, so we did an RPR. We did vitamin levels. And also we routinely do what's called an SPEP, a serum protein electrophoresis, looking, and that's a kind of a surrogate indicator for cancer and other autoimmune disorders. And in addition, and this is really for the cognoscenti on the call, we did an EMG and nerve conduction study. Now, I told you it was a small fiber neuropathy, but we're always on the lookout for demyelinating neuropathies that masquerade as axonal neuropathies. This isn't, typically HIV is an axonal neuropathy, but an EMG and nerve conduction study will tell us whether it's a demyelinating peripheral neuropathy, because that will require further workup to exclude other causes and also different treatment regimens. So she was in a fair bit of distress. She could not sleep at night. She was, and her mood was poor as a result, and she was anxious. So there are a series of medications that we use. The gabinoid drugs, pregabalin and gabapentin, are very popular, and they're popular for two reasons. One is they don't interact with antiretroviral therapy, which is entirely metabolized through the liver, and that's a serious consideration all the time. The other thing is they're fairly well tolerated. They can be stopped and started without too much trouble. So we offered her that, and she opted for pregabalin. There are other considerations, though. We could have used duloxetine. That would be starting at a low dose. One thing that is of note for clinicians on the call is that we don't use amitriptyline. There's actually a very good randomized controlled trial that suggests that amitriptyline is not beneficial in HIV neuropathy. And then in patients who don't want to take medication, because the pill burden is huge amongst people with HIV, we also use a topical cream. And this is not supported by randomized controlled trials. It's really, this is a concoction that I made and I use in the clinic. It's actually sort of a derivative of what's used for post-herpetic neuralgia, whereby capsaicin, lidocaine, and isosorbide is included, and sometimes we will add in gabapentin as well in a lipoderm base, depending on how severe the neuropathy is, and that can be really effective. It just reduces the pill burden, and the outcome is really variable. There's some patients who just never get better, and then there's some that it seemingly resolves, Usually it's related to how well their CD4 counts bounce back. If it gets right back to 1,000, with it well within normal range, patients tend to do better. But often many patients are left with a persistent neuropathic pain that requires one of these treatment modalities. I might just add, Isabelle, and I didn't want to get into this, but I might just say something about cannabis, because there is a randomized control trial for smoked cannabis, but actually I find that many patients just aren't interested in it. Some people report they also do topical cannabis as well. I don't think there's a randomized controlled trial, which is of course the gold standard for topical cannabis. But it seems like it's a selected few who benefit from it. People who've used cannabis in the past, they seem to get some improvement. But I haven't tested that formally. But this remains a very common syndrome. This is a global syndrome. When you think about 20% of people with HIV have neuropathy, we're talking about 40 million people globally. So it's a lot of people that are affected by neuropathy, and it's and often overlooked in the face of other medical problems that people with HIV encounter. Okay, I'll stop there.
Perfect.
Yep, thanks.
Okay. Last post-infectious pain syndrome we're going to talk about is with specifically long COVID. So we'll talk about COVID-19. It's a SARS-CoV-2 infection. Over 5 million confirmed cases in Canada, as I'm sure you're all aware, from 2019 to 2024. And it's estimated over 75% of Canadians have been infected at least once by the virus. Many of you are familiar with the acute infection experienced by people, but there's also the sequelae of long COVID. So it's estimated about 10 to 20% of people develop long COVID following post-acute infection. Some of the pain syndromes associated with this long COVID include burning pain, the dysesthesia, so the pins and needles we talked about, allodynia, hyperalgesia, and a small fiber neuropathy. The mechanism by which long COVID goes is a little bit of a black box. We're going to try to touch on it. But these are some of the other common symptoms experienced by people with long COVID. So they have brain fog, difficulty with concentration. There's associated fatigue and post-exertional malaise. Lots of pain in the muscles, kind of muscle aches and joint pain. And then there's also neurologic and sensory issues as well. And it's estimated about 55% of long COVID patients experience neuropathic pain symptoms. So this is a pretty busy summary of what's known about the pathophysiology of neuropathic pain. The big idea is that it's pretty integrated. So it's a multi-hit system. There's different components of the immune system and the nervous system that are interacting to produce this persistent neuropathic pain in long COVID. So I'll move kind of from left to right and summarize. The first one being this immune dysregulation. We've talked about this now in both of the previous viral conditions, but there's the peripheral and central sensitization causing the heightened pain experience. Something a little bit that I haven't touched on yet actually is endothelial dysfunction. So SARS-CoV-2 can use its spike protein actually to attach to ACE2, and then it infects the vascular endothelium. This can cause microthrombi and this kind of ischemic neuropathy and this hypoxia-induced axonal dysfunction. In the middle there, under autoimmune mechanisms, there's also the production of autoantibodies that target the self and cause a reduction in the nociceptive fibers, so those A delta and C fibers, leading to small fiber neuropathy. And this can occur throughout many systems in the body, not just in the periphery. So you can have things like autonomic dysfunction as well. And then lastly, on the right, the central nervous system involvement. So this kind of integrates the central sensitization and then also the pain processing systems in the brain. So things like the thalamus and the brainstem, where you're getting an altered pain modulation. And all of this is kind of to say that there's a little bit less known about the specific mechanisms, but it definitely is prevalent within this patient population. And there's a lot of different kind of targets that can be researched more in terms of trying to find ways to best treat these patients. Case 3.
Yeah, so I think Isabelle touched on a really important point is that COVID-19 is a new disease. And we don't know a lot about its neurotropism. And in the brain, my lab and others have shown that definitely glial cells like astrocytes are pretty permissive to SARS-CoV-2. In the peripheral nervous system, we simply don't know. But I think Isabelle's point about there being chronic inflammation, that seems like that's a key feature of it. Remember, SARS-CoV-2 is a big virus. It's 30,000 nucleotides long, so it's got the capacity to express a lot of proteins, and it's really immunogenic as a result. So we're kind of stepping into uncharted territory to some extent when talking about neuropathic pain in long COVID. But this is a patient whom I saw in the clinic, a 43-year-old or 40-year-old female with long COVID. And I should make the point that long COVID is more common in women than men. Unclear why, but definitely that's the case. The patient had developed acute COVID-19 2 years earlier. That was defined by cough, fever, loss of smell, myalgias, and fatigue. Very typical sort of presentation. And then about 3 to 4 months after developing COVID-19, she then began to notice pins and needles or dysesthesias in her feet and her hands, and that was accompanied by ongoing fatigue. And I have to say that fatigue is a huge issue and probably compounds the symptoms of pain as well. And these symptoms persisted intermittently, and in addition, she also reported that she had occasional clumsiness and also lightheadedness upon standing. And that's very typical. There are a lot of autonomic symptoms associated, including drop in blood pressures, orthostatic hypotension associated with long COVID. So on exam, there wasn't a whole lot to find. The cranial nerve exam and the motor exam were essentially normal. There was a little bit of dysmetria on testing coordination or cerebellar testing. Reflexes were good in the arms, except absent of the ankles with reinforcement. And she had bilaterally downgoing plantars, so there was no central nervous system involvement. However, there was also marked reduction in light touch, temperature, and pinprick in the feet. And then the patient had difficulty doing a Romberg test. She could walk in tandem, but the Romberg was positive. And then I also looked for entrapment neuropathies, use what's called a Tinel's test, and I looked in both the wrists, which were fine, and then over the medial malleoli, looking for tarsal nerve entrapment syndrome, and that was negative. So it wasn't an entrapment neuropathy, it was more of a diffuse polyneuropathy. So at that point, we were left with sort of this post-COVID condition associated small fiber neuropathy. But like the patient with HIV, it was really imperative that we look for other causes, diabetic neuropathy, syphilis, vitamin D deficiency, and autoimmune disorders, which is a huge problem. I've seen multiple patients who've come back after having long COVID or having COVID, then they come back to see me, a year or two later. It turns out they've developed new autoimmune diseases as a result. So she got a full workup, similar to the previous patient with HIV, hemoglobin, RPR, but also a full autoimmune workup. And then again, same issue as the other patient. This is for the clinicians. An EMG and nerve conduction study was done to ensure that we weren't overlooking a demyelinating peripheral neuropathy. So, next slide, thanks. So we, again, she was offered pregabalin or gabapentin as a first start, knowing that there's some side effects with that. But in this case, we do use amitriptyline and duloxetine. That often improves sleep. And because she was not on any drugs where an anti-epileptic analgesic such as carbamazepine was contraindicated, we also considered carbamazepine. But I will say that's usually lower down the list in terms of drugs that we use for neuropathic pain. And then the good news is, with time, actually these symptoms often resolve. And this has really been sort of the take-home message for long COVID, that by and large, most patients with time do better or do well. Their symptoms almost resolve. And this is supported by work from Here, my colleague, Dr. Grace Lamb, who's ran the long COVID clinic here, and she's done prospective studies. Patients with long COVID tend to improve with time. The one caveat is if they develop a concurrent other disorder, another underlying disorder like an autoimmune disorder, then that can be problematic going down the road. But overall, the picture for long COVID associated neuropathy is better than it is, say, for HIV neuropathy. So we'll stop there.
We have one more slide.
Yeah, all right.
Just wanting to highlight, so we've talked about 3 viruses that can cause neuropathic pain, just highlighting that these aren't the only 3. So I just wanted to briefly summarize some of the other viruses that can have pain-related syndromes. So the first 4 viruses listed there belong to the Flaviviridae family. Hepatitis C is actually a hepacivirus. It can cause mixed cryoglobulinemia, which is essentially an abnormal clumping of proteins in the bloodstream. It can cause vasculitis and inflammation. The next 3, so West Nile, Zika, and dengue, are all flaviviruses. They can cause a variety of different neuropathic syndromes. So Guillain-Barré is a syndrome where there's weakness and tingling, usually in the lower extremities. You can get facial paralysis, pain, and respiratory paralysis. And then West Nile can cause pretty neuroinvasive infections that affect nerve roots and the peripheral nerves, and can be associated with an acute flaccid paralysis. Epstein-Barr virus, so EBV, and herpes simplex virus 2, HSV2, and cytomegalovirus, so CMV. Those 3 all belong to the herpes viridae family. EBV can cause a peripheral nerve inflammation. Both HSV2 and CMV can cause Ellsberg syndrome, which is kind of a rare syndrome. It affects the lumbar sacral area, and it can cause this radiculitis, and they can also be associated with a variety of polyradiculopathies. And then lastly, the D68 enterovirus belonging to the Picornaviridae family, and it can cause an acute flaccid paralysis with neuropathic pain. So this is all just to say that the 3 that we touched on, they're common, but they're not the only ones that can cause these sequelae of neuropathic pain syndromes. So this is just to summarize. You've seen this slide, 4 mechanisms of viral neuropathic pain. The 3 viruses that we talked about can cause these through a variety or combination of the mechanisms. And yeah, I think that's all we have, really. Time for questions.
Great. Thanks for everybody's attention. And also I want to commend Isabelle. Those figures, schematic figures that she presented, she actually made them herself. So well done, Isabelle. That's a fantastic job there. Really good. Good. Yeah, we're open to questions if anybody has any questions.
Thank you both so much. And yeah, I was admiring those figures. That's